I think now we'll begin with the revision ACL session. I think the imaging in ACL should be start with the focusing on how the actually what is the cause of the failure of the to find out the cause of the failure of the ACL reconstruction, and we know that it may be either due to the graft failure, due to the complete rupture of the graft, or due to the non-healing of the graft or stretching of the graft. So you need to find out what exactly is the cause of graft failure, or whether it was due to biomechanical failure, due to tunnel malposition, or improper graft tension, or it may be due to the re-injury. So I think this is another just case of a diagnostic arthroscopy. As you can see, the ACL graft was actually okay, but actually due to malposition, it was not functioning well. So this is also a cause of the ACL failure. So I think you can see the new tunnel was exactly in the anatomical position, and you can see that the previous tunnels was in the quite anterior and superior position. So I think in this sort of situation, even if the graft is well preserved, then probably it will not function like an ACL. So this is also a cause of the graft failure. As you can see, the new tunnel position, old tunnel position was here. So I think you need to understand that not only due to what are the cause of the failure, you need to whether it's a recurrent tear or the persistent instability, you need to also assess the joint degeneration also. But we know that after ACL reconstruction as well as in failed reconstruction, the joint degeneration starts early. So if you look into the X-ray, which is probably the basic investigation after the ACL reconstruction or even of the failure, where the investigation you do, it usually helps in identifying the tunnel position, particularly in the lateral view. You can see the tibial tunnel very well, but for the femoral tunnel, probably the X-rays does not give you a good idea. But so you can have some idea regarding joint alignment as well. But I think for the joint alignment, you need to do the scanogram. As you can see in this small view, the posterior slope was not looking almost normal, but if you do an good scanogram on lateral view, this posterior slope looks quite high. So I think this is probably one of the most important investigation for doing the revision, the ACL imaging. What exactly you need to know, you need to have the lateral view of long leg of both the legs, and these sort of situations probably if you are dealing with in a revision or re-revision scenario, probably deflection osteotomy might be required. So I think in MRI, you need to evaluate the graft properly, whether it's a lax graft is there or not. Regarding the bone tunnel assessment, I think probably MRI is not the very good idea, but I think it will give you some idea regarding the tunnel dilatation both in femur and the tibia, and probably is best for the associated injury in case of re-rupture of the graft, whether the meniscus tear is there, what is the status of the cartilage, and if there is any synovitis or infection is there or not. So as far as the CT scan is concerned, probably is the investigation of choice in these sort of situations, because we know that the future treatment plan, like whether you can do it in the single stage or double stage, depends a lot on the CT scan finding what is the tunnel dilatation. We know that the tunnel dilatation is not exactly, in the uniform way. It's maybe the apertures are narrow, but I think the central part you can have the fusiform dilatation. So all those things you need to measure at the widest part. That probably is one of the criteria whether to do it a single stage or double stage. I think it will be dealt nicely by the next subsequent speakers. But I think this is not the only the tunnel dilatation which gives you the idea regarding whether to do it a single stage or a double stage, but it's a multifactorial. You need to talk to the patients, whether need to the patient out expectation and everything taken into consideration. Then only you decide the graft choices which are available. If the bone plug is available, then probably you can tackle the more dilated tunnels. If the bone plug grafts are not available, then probably soft tissue graft you can probably stage in these sort of situation. But I think if you have one criteria which is probably there in majority of the paper, 15 to 16 millimeter is probably considered the cutoff for doing the single stage and double stage revisions. So probably the CT scans are the way to go. And if you do and digital the subtracted the femur and the tibial, then you can have a good idea exactly about the tunnel position. So I think these are the most important things. You need to study all those things very nicely and in details, and then only you decide to plan for the revision surgeries. So I think at the last I would also like to give you the arthroscopy or diagnostic arthroscopy is probably also one of the investigation part of the revision surgery, because it's probably is the gold standard in revision surgery. For the primary also, we tend to do the diagnostic arthroscopy, then proceed for the surgery, and it becomes more important in revision surgery. So I think this diagnostic arthroscopy confirms your imaging findings, and it identifies the soft tissue injuries, probably the graft stretching, graft laxity, and graft integration with your tunnel is probably not that confident while assessing the MRI as well. So I think that during the diagnostic arthroscopy, this will give you the best idea what is the status of your soft tissue graft. And of course, you need to have a good idea regarding the viability of the graft or associated injury as well. So I think the take home, I would like to say that the imaging in revision arthroscopy, you need to focus on your imaging so that you can get an idea regarding the cause of the failure. And in this gives you highlight how to tailor the revision surgery, like whether to put the tunnel position, what is the graft condition and associated injuries. So that's from my side.
Next talk we have Dr. Sunil Apsangi. Tell us about the graft options, and Dr. Sunil is from Hyderabad. Thanks for chipping in. We appreciate it, Sunil.
Morning, everyone. Thanks for this opportunity. So, why graft choice matters in revision ACL? It is because there is bad biomechanics and bad biology. Revision ACL-R has a higher failure rate, and it has been reported to be around 10 to 15%. So what is the goal in revision ACL? It is to do a durable stability, give a durable stability with acceptable morbidity in a compromised biological and mechanical environment. So we need to be aware of prior graft type, tunnel position, whether it is centric, eccentric, tunnel widening, bone loss, concomitant instability, other ligaments involved, patient's age, sport, and expectations as well. And there are various grafts which are available. We all know about this. They are the autografts, which can be ipsilateral or contralateral, bone patellar tendon bone, hamstring, squats, and off-late peroneus graft. And allografts include the bone patellar tendon and other soft tissue allografts, which you are all familiar with. Now we also have these synthetics. They always come up once in a while. But I'm not going to discuss much about them because there is not much evidence to support their use in revision situations. And we always see this in revision cases where you have eccentric widened tunnels, and now this is a big problem for us. And sometimes they need two-stage, wherein you do a bone grafting and then come back and redo the actual ACL reconstruction. So if you look at level of evidence for revision graft choice, most of these are prospective or retrospective cohort studies, registry data, high quality multi-center cohorts, and some systemic reviews and meta-analysis. Of late, they have been focusing on autograft versus allograft, quadriceps tendon versus hamstrings versus bone patellar tendon autograft, and also the graft type and return to sport criteria. So if you look at autograft versus allograft, this is the MAS study, one of the biggest studies. This was their first report in 2014. They studied more than 1,200 revision ACL-Rs, and they had almost equal auto and allografts. At 2 years, they said that autografts are associated with lower graft re-rupture rates and lower reoperation rates. They reported similar patient-reported outcomes, and they concluded that autografts are far, far safer when compared to allografts. They came up with their second report in 2021, and this was 6 years follow-up. They had more than 900 patients, and they found that BTB autograft patients had 4 times less likely than a BTB allograft. And there was no difference in re-rupture rate between BTB autograft and other soft tissue autografts. And patient-reported outcomes were similar across all groups. Rest of the grafts, they were doing reasonably well. One more meta-analysis, again they compared ACL outcomes for revision with auto and allografts, and they found that allografts had higher risk of failure, not a surprise, and there was no major difference in return to pre-injury activities or PROMs. In this study, they had 97 revision ACL-Rs with all autografts, 40 quadriceps tendon, 26 hamstrings, and 31 bone patellar tendon. And they found no significant difference in functional outcomes at 2 years between all the 3 groups. However, the graft failures, if you note, were slightly higher on the hamstring side as compared to a bone patellar tendon or a quadriceps tendon. This was not significantly different in their statistics, but the numbers are too small to give any statistical importance. In this study published recently, they evaluated the outcomes of a quadriceps tendon graft and compared it with hamstrings and bone patellar tendon graft. Quadriceps tendon graft, as we all know, is a pretty robust graft and you can get a good thickness graft. And there is no difference between re-rupture rates between quadriceps tendon and bone patellar tendon. So they have said that quadriceps tendon is a very good alternative for revision ACL-R. In this study, they have studied only the allografts, that is the bone patellar tendon allograft versus the tibialis anterior and Achilles tendon allografts. Now, we are getting more and more allografts available in India, so it's very important for us to know. They found that the bone patellar tendon bone cohorts exhibited lowest failure rates when compared to both tibialis anterior and Achilles cohort. The tibialis anterior rate group performed better than the Achilles cohort. And more worryingly, they found that infection rate was higher in Achilles tendon allograft patients. So coming to return to sports, this is a meta-analysis recently published, and pooled data showed that there was no significant influence of graft choice on the rate of return to sport to pre-injury levels. There are other factors which probably are more important, which include the age, sports type, concomitant injuries, psychological factors. Message is choose a graft which is good for the patient. Regarding single stage versus two stage, most of the articles say that both of them do well. However, one article says that two stage actually gives a far better graft survival. Allografts, we all know the advantages. They avoid donor site morbidity, shorter surgical time. Disadvantages, high failure and worse results when they are irradiated or chemically processed, best used in low demand patients or multi-ligament scenarios. We all know this, failing to prepare is preparing to fail. So how do we avoid this? Recent article published in AJSM, New Zealand Registry, they have compared suspensory fixation versus screws, and they found that suspensory fixation on both sides resulted in lesser revision rates. It is not unusual for us to find this, where you put a screw and after 2 years you find the screw intact and a big hole there. Whereas with a suspensory fixation, you can see on the left side that the tunnel has healed and it is complete bone there. You can see this even on the MRI scan. On your right side is the screw, on the left side is the suspensory fixation, and you can see how well the bone has healed between the graft and the suspensory fixation device. This you can see even with a metallic suspensory device, so not necessarily a non-metallic suspensory device, even with a metallic suspensory device, you find that the bone heals. There are other factors other than the graft choice which are more important when you go in for a revision ACL. The failure risk is strongly influenced by other instabilities, by meniscal deficiency, technical errors, very, very important, coronal and sagittal plane malalignment. So graft choice is important, but not a substitute for comprehensive instability correction and sound surgical technique. So we can see this evidence-based algorithm for graft choice in revision ACL-R. Step 1 is analyze why has the ACL failed. Step 2, stratify by age. In younger patients, we prefer autografts. If it's prior bone patellar tendon, you can use a quads tendon. If it's prior hamstrings, then you can either use bone patellar tendon or a quads. Avoid allograft unless it's really essential. In more older age group, then you start giving some preference to allograft, but in general, autografts are far more preferable than the allografts. Thank you.
Thank you, Dr. Sunil. That was a great insight. You can join the panel. That opens to our next discussion, whether to do a single stage or a two-stage revision. I invite Tarun Goel to give his talk on single stage versus two-stage revision in revision ACLs.
A very good morning, everyone, and I'm deeply thankful to Dr. Parag and Dr. Sachin for having me here. My topic is to discuss single or two-stage revision ACL reconstruction strategies and the indications and results. So once we have a failed ACL and we need to decide whether it's a single-stage revision or a double-stage revision, I would like to say that you would have specific indications for doing a single stage or a double stage revision, so it's not a debate that single stage is better or double stage is better. Double stage would mean that in the first stage you would debride the old graft, debride the old tunnels, do some bone grafting, and then ligament reconstruction will be followed at about 4 to 6 months once the bone graft has consolidated. And in order to decide whether you are planning for a single stage or a double stage procedure, you need to look at the tunnel location, the old tunnel diameter, the previous hardwares, the size of the hardwares, and the amount of bone loss that you're going to have if you are to remove that hardware, and the biology of the local bone in terms of the future graft healing. So if you look at what the literature tells us about one stage versus two stage, there are no studies which are directly comparing the outcomes of single stage and two stage revisions in literature. Reported results of the consolidated studies separately on stage 1 and stage 2 have shown that the patient reported outcomes are similar whether you do a single stage or a two stage revision, but there may be a lower rate of repeat revision surgery and clinical failures, as also mentioned by the previous speaker. So what you need to look at is what bone graft you are looking at, what interval you are looking at between the first and second stage, what tendon, as has been discussed before, what are your indications. Most importantly, what are your indications for a single stage or a two stage revision, and what clinical outcomes you are looking at. So we have, this is a Danish knee ligament reconstruction registry which has studied 1574 ACL revisions. Majority of them were single stage, as you can see, and most of the literature has shown that majority of the revisions that has been performed in literature are actually single stage revisions. There was no statistically significant difference in 2 years in the revision rate between the two groups, and we did not see any statistically significant difference in knee laxity scores or pivot shift test between the two groups at the follow-up. So clinically and functionally, both the procedures has been doing well, and both groups demonstrated significant improvement in knee stability from baseline. And they have also shown that patellar bone tendon graft was the most commonly used graft in the single stage revision group, because if they are doing at a single stage revision, probably they were looking at a graft which could give them a bone as well. So the hamstring graft was used in only 21% of the patients, but if you are looking at the same with the two stage group, the number of cases with the patellar tendon bone graft and hamstring bone graft were almost similar. So the systematic reviews and meta-analysis on stage 1 and stage 2 revisions. So this was published in 2021 and there has been no systematic review after that. It included 13 studies that met the inclusion criteria, but it is interesting to note that only 2 studies they could see where some comparison was made between the stage 1 and stage 2. So, but no randomized studies are available in which the patients were actually randomized into stage 1 and stage 2. Both the studies, the patients were taking stage 1 and stage 2 depending upon the indication of whether it was a single stage or a 2-stage revision. So there was no difference in functional, radiological or patient reported outcomes of failure risk in both the groups. So the available evidence comparing 1-stage versus 2-stage reconstruction is retrospective and limited. That was the conclusion of the review. This was a previous systematic review in 2018 in which 3 studies which reported outcomes of 2-stage and 21 studies with single stage. So again we can see that single stage was much more common than a 2-stage revision. And the findings were that when you compare the results of the studies, the outcomes were comparable. No study randomized patients to stage 1 and stage 2 reconstruction, and there are probably 2 separate groups with separate indications. This study had 88 patients of revision ACL reconstruction, which again was divided into 2 groups for stage 1 and stage 2, and were found to be the clinical outcomes and the patient reported outcomes were found to be same between the 2 groups. And interestingly, again, they had separate indications for one-stage revision versus a two-stage revision. So the one-stage revision patients would have an anatomical tunnel location on both the femur and the tibial side, so that you could probably use the same tunnel with adequate bone stock, no tunnel dilation. So if there's dilatation of the tunnel more than 14 millimeters, that would be an indication for a two-stage revision, because you would like to bone graft the tunnel before putting a new tendon inside it, or a non-anatomical tunnel that did not interfere. So you can just ignore the tunnel because the previous tunnel had been made in a non-anatomical location. But two-stage revision, the tunnel malposition that interferes with placement of the new tunnels, suboptimal bone stock, tunnel aperture of more than 14 millimeters. So if there's tunnel dilatation or large aperture, inability to anatomically place and secure the graft during the procedure. So absolute indications for a two-stage may be an active infection, a large footprint, substantial bone loss, or an arthrofibrosis. Preoperative evaluation, as we have seen in the first talk, you have to look at the tunnel position, tunnel enlargement, alignment of the tunnels. That can be available on your preoperative radiographs. The AP and lateral radiographs will be able to tell you a lot of story that what has been happened in the past as far as your previous ACL reconstruction was concerned, and how is it going to affect your future. So the tunnel malposition can be seen on the standard preoperative radiographs, but we would also recommend that you have a CT scan in which you would be able to see the tunnel dilatation. Old tunnels should be assessed for expansion and bone loss. Sometimes the femoral tunnel may be far behind, which could have led to a posterior wall blowout, or you would not have any bone left in the posterior part. So when the tunnel expansion exceeds 14 or 15 millimeters, it becomes an indication for a two-stage procedure, followed by a delayed second stage at 4 to 6 months. Now, this is important to look at the tunnel overlap. Tunnel overlap would mean that you would like to place your tunnel anatomically now, but the previous tunnel was placed so that it partially overlaps with the new tunnel. So what do you do once the femoral tunnel has been classified on the CT-based classification again into a well-positioned tunnel, which is not dilated, which can be reused as well. Slightly malpositioned, now that becomes a problem because it's an overlapping tunnel, you cannot ignore it, and once you make a new tunnel, it is partially overlapping the new tunnel. So what we'd like to do here, if the tunnel overlap is more than 25%, you cannot generally ignore it. You would have different techniques of doing it. You can use a technique like a stacked screw fixation, in which remove the previous hardware and ream the tunnel, then fill it with a composite screw which is more than 2 millimeters, and then put a new graft and a new screw in its position. Or over the top femoral tunnel if there is a large blowout behind. Removal of the previous hardware is not always required, and you can carefully drill through the previous biodegradable interference screw to minimize the debris. So to conclude, femoral and tibial tunnels should be rigorously planned. Appropriately placed tunnels can often be reused, whereas significantly malpositioned tunnels can be ignored. Overlapping and enlarged tunnels create a challenge, and they has to be tackled by different techniques. One or two stage revisions have different indication, and one stage is reported more commonly in literature, but outcomes of the two techniques are similar. Thank you.
Yeah, any questions from the floor?
Yeah, so I have one question. The first talk was very good, Dr. Hazra. My question is, in every case where we are going to do a revision ACL reconstruction, is it mandatory to get a CT scan and an MRI, or at least a CT, or both? What is your take? Whenever you're doing a revision ACL, is CT mandatory?
Yeah, I think in majority of the case on your X-ray you will have some idea regarding the tunnel position and tunnel dilatation. If you don't have an idea, if you are finding it difficult to get, I think it's mandatory to get the CT scan as well. So there is, I think this is a revision scenario. So I think it's better to have proper investigation done, and you assess the your problem properly, and then go ahead with the surgery.
So on what basis, Tarun, do you decide whether you want to do a two-stage, one-stage? How important is the tunnel dilatation for you? I think that one specific point, can you highlight a bit? Because as a surgeon, I've seen in my practice, I always want to do one stage, but sometimes, you know, we on table we decide the tunnel is too wide, and then you've not counseled the patient for doing two-stage, you do the bone grafting first, and that becomes a problem. So any guidelines, any thoughts on this?
As far as the literature is concerned, there is no single figure quoted in literature which would say that if the tunnel diameter is more than this, then we go for a two-stage. Different studies have quoted ranges between maybe 12 millimeters, some have said 14, some have gone up to 16. Some have even said that a larger tunnel on the tibial side may be more acceptable, and a small tunnel on the, there's a lower threshold on the femoral side. But by and large, if the tunnel is more than 14 millimeters, it may be difficult to place a new graft and secure it
Then
properly.
you would bone graft it, and then because even if it is 12 or 13, then your graft may occupy 9, 10, 11. So the remaining part, then use a metallic screw. You know, suspensory fixation is out of question in these situations. Then you always have to use a biodegradable screw. Yeah.
One is like a stat screw, or you can use a two-screw method, or you can probably use a single-stage bone graft as well as the fixation with the new graft.
In that case, Dr. Parag, we use bone patellar tendon bone graft for that. Ideally, you get around about 11 or 12 mm also bone patellar bone graft. And along with that, you can adjust with your stack screws if needed, if you want to do it in single stage. Double stage, if you want to do, then you can do a bone graft for that and then come on the lateral date for that.
Yeah. Question to you, Sunil, is that in the case of a failed hamstrings ACL, let's say there's a failed hamstrings ACL and you want to revise it, can you again use another hamstring, or should you be moving to a bone plug type of construct?
I think, to me, sir?
No, Sunila.
Say, the problem with hamstrings is when people start using hamstrings with the screw, then you have the problem of tibial tunnel, because femoral side is more often than not is not a problem for us. We are able to manage the femoral side.
Let us leave out tunnel dilatation out of the equation. So let's say tunnel dilatation is not the challenge, but my contention is that if you are drilling a new tunnel, can you again use a soft tissue graft when your first soft tissue graft has failed, or should we be moving to a bone plug? And I'd like your answer and the opinion of the panel.
The failure is not, the failure of the graft has to be determined first. If it was because of technical reasons, then yes, you could always use another soft tissue graft as long as your tunnels permit you to do that. If your tunnels are dilated, then it's out of question.
So in the situation of dilated tunnels, definitely bone plug is preferred. But if the graft has not failed because of the positioning issues, then even same hamstrings can be used, contralateral leg hamstrings or peroneus tendon or soft tissue grafts.
I have used, I think, the peroneus in revision surgery for soft tissue graft after the hamstring failure. So that thing, I think it's probably can be used if the tunnel dilation is not an issue.
For me, hamstring failed grafts, always BTB. Along with that, do a LET procedure for that.
Okay. Tarun?
The graft failure, as far as you know, it's mentioned the literature, the young patients with a soft tissue graft failure, for example, a hamstring graft failure in a young patient undergoing a revision ACL surgery, the results of hamstring graft have been found to be inferior as compared to a quadriceps tendon graft or a bone patellar bone graft. So I would say that particularly in young, which would mean less than 40 years of age, the second graft choice should be a quadriceps tendon or a bone patellar bone tendon graft.
And how many on the panel will harvest contralateral graft? Graft from the contralateral limb. Why? Samir, can you ask with a show of hands, how many people will prefer to have?
Yeah. Can you have show of hand? How many people would like to harvest the contralateral graft as well? That's not only two.
For revisions.
Three, yeah, for revisions. Okay. The majority of you prefer the same side graft, isn't it?
So that was a good moderation. I'll invite the panel for group photos.
One question to Sunil before you take the photograph. So this quadriceps tendon graft is becoming quite popular now in the revision scenarios, and you also mentioned it. So any tips and tricks on how to harvest this? Because we've seen the whole gamut where you expose it and then do it open. We saw the stripper which was developed, the closed one, and now there is another blade which you can slide. So which is the best way to harvest the quadriceps, and do you always have to take the bone plug with it or without for revision scenarios?
It can be done both ways depending on what you want to sort. If your bone tunnel is not enlarged, then you can do a soft tissue quadriceps graft. If your bone tunnel, if you want to plug one of the bone tunnels with a bone block and it is just on one side, then you can take it with a bit of bone. And yes, there are lots of ways described in the literature and there is lots of instrumentation being thrown around, but I think it's a pretty simple, straightforward harvest procedure. It hardly takes a 2-inch incision. And I think it's more about having the appropriate equipment, especially if you're taking the bone plug out, then you need the proper saw, proper this thing. If you're just taking a soft tissue graft, then normally I tend to take almost full thickness quads tendon graft. I don't try to take a partial thickness graft. I take a full thickness graft because then it gives a very big graft which can be very easily accommodated in the tunnels.
We avoid to violate the joint and kind of go into the capsule and the suprapatellar pouch.
Yeah, that's always the goal, but joint always gets violated.
Yes, that's what I've seen in off late. That's why I moved to a partial thickness. But sometimes in the initial part when I used to use the quadriceps, invariably we end up opening the joint.
Thank you, everyone. Thank you.